seminar. It is for the prostate cancer, and this is meant basically about the advancement in the oncology.
Some patients don't know where the prostate is, what the prostate cancer, and what causes prostate cancer, and how common is prostate cancer, what are the risk factors for developing prostate cancer, how can we prevent prostate cancer, and test of prostate cancer, and what can we do. Actually, many patients, because they think that prostate in this problem, and this is very common thought in the patient, that they think that prostate may be scrotal. We have to inform that prostate is a deep organ. It's around the urethra, below the bladder itself. And as a function of the prostate, it's not sexual function. Actually, it's productive function, secreting part of the semen, and it's big part of the semen coming from the prostate. And the prostate has nothing to do with sexual activity. Catheter prostate, as we know, is developed in the prostate itself, in the either in the acinine of the prostate, and this is the most common, or in the duct of the prostate. For the incidence of prostate cancer, as we know that prostate cancer is the most common cancer in men, and the third mortality in men after colorectal and lung cancer. So it's highly prevalent for the first prevalent, and it's the third cause of mortality for men. It's most common, as we said, it's most common cancer in men, and it's the third mortality, and there's the high incidence in the African American and Caribbean American, the Hispanic people. It's more prevalent. The prevalence there is about 150 cases out of 150 per 100,000 population. The incidence decreased from the west to east, and reached in our area about 70 to 80 in 100,000 men, and in the far region it's more due to environmental, genetics, and dynamics. The cause is unknown, but genetic factor and aging, genetic factor, and also the family history, and racial factor. This is the most common attributed to prostate cancer development. Estimated the age estimation is 1 in 19 men will develop invasive prostate cancer at age 60. And the rest, as I said, is African American or Hispanic, and positive family history. Genetics like BRCA mutation is the risk factor for prostate cancer, and factoring happens also for eating more fat and more meat, and less vegetable oils. This is the risk factor for prostate cancer. Actually, most of prostate cancers are asymptomatic, but rarely the patient could be presented with hematuria, and sometimes obstructive prostatic symptoms, but most of prostate cancer is discovered incidentally during routine examination or during screening. Can be prevented. Actually, there is no strong study about the prevention of prostate cancer, but whenever it happens, this could attribute to cancer prevention in prostate cancer, and early screening for early detection. This is some studies about the effect of diet on the prostate cancer, and you can see that maintaining good weight, this is a factor, limit amount of red meat and fat and dairy products, and eating more fruits and vegetables. Vitamins, there is no big role for vitamins in the prevention of prostate cancer, but there is some weak studies about the vitamin E and selenium in the prevention of prostate cancer, and lycopene, which is present in the canned tomato or in the tomato, and also had been studied showing some effect on the prevention of breast cancer. If we talk about the prostate cancer screening, actually we have different guidelines for prostate cancer screening that is different from the American guidelines, the European and UK, and also in our area. For the cutoff value of PSA and the start of screening, the age of start of screening. But the standard for screening of prostate cancer is through PSA and digital rectal examination. Actually, if the patient asks about the prostate cancer screening, we have to answer that. Prostate cancer screening is risky because there is over-treatment of prostate cancer, especially in the some Muslim countries. In the USA, we have over-treatment of prostate cancer. Patients can survive with prostate cancer without treatment for life, and they can die from other reasons. That's why early detection and screening is risky, that the patient can be over-treated. Actually, we have to inform the patient about the decision to get prostate cancer screening, because if the PSA is high, so we have to go for the next step. And the next step will go for the other step, which is treatment. So we have to be cautious about the screening of prostate cancer. The recommendation for prostate cancer screening starts from the age of 50 until the age of 75. For low-risk patients. Low-risk patients mean there is no family history of prostate cancer, so we can start screening of PSA at the age of 50. Especially if the patient has a life expectancy of more than 10 years. So if the patient has life expectancy of more than 10 years, you're going to have benefit from the active treatment of prostate cancer. We start at the age of 45 if there is a positive family history of prostate cancer, especially for the father or the brother, especially if they got a prostate cancer at earlier age. But we start at the age of 40 if there is more high risk for more than one member of the family, or one of them developed early cancer before the age of 60. What can we do if there is the high risk of prostate cancer? Actually, we do this usually at the age of 50s and 60s. The cutoff value of PSA in USA is 2.5. If the patient has PSA is 2.5 or more, he needs follow-up and he needs frequent screening. Our cutoff value here for PSA is 4. So less than 4, usually we do the routine follow-up for PSA every 2 to 4 years. I make it very short because of the time, and I try to make it as what is the common question that asked by patient about the prostate cancer. So we will have any questions.
Thank you, Dr. Mohan. So I'm sure there are some questions in the audience.
Okay, just now we finished
If not,
presentation
please,
on
elaborate
prostate
more
cancer
about
screening. From this seminar, what we came to know that it is recommended to go for regular screening, and initially PSA, prostate specific antigen, will be one of the important key factor. Also, they should go for digital rectal examination, and if PSA is high, then we need to go for further examination.
We can do active surveillance. Active surveillance means that we watch the patient and do frequent PSA, and we do also digital rectal examination, and if needed, to repeat the biopsy for reproduction. This is active surveillance. So some tumors can be treated conservatively. The second line of treatment is for medium and high risk tumors. We do surgical management. Surgical management is radical prostatectomy, including either with nerve preservation to reserve erection, or without if there is a locally advanced tumor. What's equal or near the treatment, surgical treatment, is radical therapy. This is localized radiation for the prostate, and it's coming with the almost equal result with the surgical treatment. For advanced tumors, locally advanced tumors, or metastatic tumors, we have to go for local radiation plus hormonal therapy, and in some cases with the chemotherapy.
The common questions which we face in the outpatient is, Doctor, can I have a TURP as a treatment for my prostate cancer?
Actually, TRP is a treatment of benign prostate enlargement, obstructive prostate. TRP, we do it for advanced cases, which is inoperable, with obstruction with prostate cancer. Means we call it tunneling of the prostate. Means that the patient has advanced prostate cancer and it's not surgically treated. And he's on hormonal therapy or prostate therapy and he has obstruction. We can do for him TRP tunneling, just the relief of obstruction by transurethral resection of the part of the prostate. But it's not radical treatment, it's not classic treatment for prostate cancer.
And a lot of patients would have heard about orchidectomy as a treatment of prostate cancer. Please elaborate. Orchidectomy.
Okay. Actually, now it's orchidectomy replaced completely by hormonal therapy. Nobody doing orchidectomy right now, but it was the classic. As we know, it's in 50s, the 1950-52, Young discovered that prostate cancer is hormonal dependent. It's built on the testosterone. That's why he started to do orchidectomy for the patient to reduce the testosterone and to improve the outcome of prostate cancer. But right now we have hormonal hormonal surgery is GnRH analog, and we know this will address suddenly testosterone production in the body and will degrade the metastasis and degrade the PSA and reduce the tumor and improve the survival. Combined with anti-androgen. But orchidectomy is not frequently practiced since for the last 10 years.
It is very similar to our treatment in breast cancer. So both breast and prostate cancer are hormone sensitive. So we used to do hysterectomy of breast cancer and orchidectomy of prostate cancer. They have a any further questions?
Thank you, sir, for nice introduction. Sir, there is some patient of undescended testes, in case of male. Is there any relation with undescended testes and prostate cancer?
Actually, this is increasing the risk of testicular cancer by 40 folds. But it's not related to the prostate cancer. It's testicular cancer.
Because sometimes we get some patients, those who came in the age around 30 or 35, we know that undescended testes should go for surgical correction earlier. But if they come after the age of 35 and now they are worried about the prostate cancer, so what kind of advice we should give them?
No, there is no risk of no relation between the testicular, undescended testicle and the prostate cancer. Actually, by the way, for the undescended testicle, if the patient discovered after the age of 12, it must be go for orchidectomy.
Yes.
No fixation at that age. Fixation usually for the age of 12. After that, he has to go for orchidectomy because of the risk of testicular cancer, not because of the prostate cancer.
Okay. Thank you, sir. Thank you.
Any further questions? If there are no further questions, thank you, Dr. Mohan. For our last talk of the day, I'd like to invite my senior colleague, Dr. Adhikary, consultant, OB-GYN at University of Moscow.
No, this is a free seminar actually organized by NMC Royal Hospital, Sharjah in UAE. And along with me, I have Dr. Wasim.
He will be giving us a talk on ovarian cancer, the silent killer.
Okay, now we are moving to ovarian cancer. If you have any specific question, please you can write. Malayali. Malayali, no, it is not Malayali. No Tamil. Hindi, okay. Hindi and English. I'm sorry. Okay, so from the previous presentation, there is a question raised. Actually, I asked that undescended testes and prostate cancer, is there any relationship? So answer is straightforward, no. There is no relationship with undescended testes and prostate cancer. Rather, where there is a relationship and high risk of testicular cancer, not prostate cancer. Okay, thank you. Now we will move to ovarian cancer.
Ovarian cancer is about 1 to 91. So the lifetime chance of dying from is approximately 1 in 40. Compared to the other cancers, the death to incidence ratio for ovarian cancer is a bit high. So ovarian cancer is the highest one. We know that the poor is always carries a poor prognosis and it is rarely cured. Ovarian cancer arises from complex integrity of genetic understanding these
Not satisfying.
Not satisfying all the individuals and preventing preventive strategies. We have the high risk, the increased risk factor for ovarian cancer, and it
is giving very good presentation about
previous
cervical
and hereditary cancer syndrome,
Egyptian.
obesity, having never
What?
given
This
an
kind of
HRT
activities,
and
like-
number of lifetime ovulatory cycles. For the decreased risk for ovarian cancer due to bilateral staphylococcus, oophorectomy, bilateral staphylococcus with ovarian retention, hysterectomy, tubal ligation, and the use of oral contraceptives as well as breastfeeding. For example of the high-risk ovarian cancer, as we all know, in addition to BRCA1 and BRCA2, this is considered regress as well as ovarian cancer syndrome, and the Bench and Crowley syndrome and Fitzgerald syndrome. The Journal of National Cancer Institute notes that approximately 4% of ovarian cancer have a family history of breast cancer, as well as 12% have a family of ovarian cancer. So the types of ovarian cancer depend on which has been originated. So we have epithelial cell tumor, that is arranged in the cells that cover the outer surface of the ovary, which is the most tumor of the epithelial cell tumor in about 9 in 10 cases of ovarian cancer involved epithelial tumors. We have also germ cell tumor, it is starts from the cells that produce the ova in young women. Sex chromosomal tumors start from the structural tissue that hold the ovary together and produce the female hormones like estrogen and progesterone. These are just samples from the ovarian cells.
Hemorrhagic.
So the cellular origin of ovarian cancer is originated from the epithelial surface of the ovary as well as the epithelial surface of the fallopian tube. This will both lead to have high-grade serous carcinoma or low-grade serous carcinoma, as well as if the origin from the endometrium in a woman having retrograde dysplasia, endometriosis, She might have clear cell carcinoma or endometrioid carcinoma. Other might have mucinous carcinoma. So the most common subtype of ovarian carcinoma is the most lethal type. So this is the type we use that we're having. The high-grade serous carcinoma carries the incidence 70-74% of the cases, which is also the most lethal type. For the clinical practice guidelines for the assessment and diagnosis of ovarian cancer, equally clinical presentation of patients of blood culture symptoms. Very real symptoms before lesions with ovarian cancer you will have, or the ovarian cancer, and rarely they will seek gynecological advice. She might have blood, or she might have a pelvic or abdominal pain. She might have an epicyclitis, or she's feeling that she cannot breathe anymore. She might have a weight loss, or she might have urinary symptoms like frequency or urgency, and she doesn't go to the gynecologist. Usually she's going either to our colleague or GP doctor. We have to have concerns from biomarker like CA125. Sometimes incidental finding depending on previous surgery or pushbacks. So the non-specific nature of these symptoms often lead to misdiagnosis or delayed diagnosis. Research published in the National Journal of American Association that 95% of women with ovarian cancer experience symptoms prior to diagnosis. Yet not enough people are being for that diagnosis until the disease is advanced or late stages. So 90 to 60% of women with ovarian cancer often diagnosed with advanced disease, which is very advanced cancer. So what is the first step in the primary care? The first question to be asked in the primary care is to find out the serum biomarker CA125. It is more than 35 to the ultraviolet abdomen and
Yeah, hi Asel. If you have any specific question, you can ask me.
cancer, urgent referred to the running approach. It is less than regular, assess carefully and other clinical causes of the symptom, if it is resistant to the investigate, based on she can go back to the So what are the diagnostic criteria of ovarian cancer? Many by ultrasound, ovarian volume more than 10 to 20 centimeters, but there is no difference. Cystic, solid, or complex. Complex means solid cancer. It is morphology related to the thickness of the cystic wall more than 3 millimeters. If it is substance thickness more than 2 millimeters, it is bidimensional. But there is capillary projection. I can add also a 5 millimeter. Also diagnosed by Dr.Adhikary, if there is increasing vascularity and reducing resistance. CA125 and we have this one, we have evidence for support. Actually, this one is not used for the screening, this is used for the detective and preparation and after treatment, treatment and the response. This is a simple ultrasound picture of ovarian mass, ovarian specific ovarian cancer. A suggested finding that the amount of the ovary was a centimeter irregular in the presence of capillary projections in the center, as well as the site. MRI is not be shown to have a clear advantage over the CT in patients with ovarian mass. So after ultrasound, the doctor will have to go for CT scan. And if there is contraindication for CT, the patient is pregnant, then you can go for MRI. So MRI does not be shown to have a clear advantage over the CT, except for a presentation of ultrasonography inconclusive and the desire of what the patient is exposed. According to the oncology guidelines, we have to measure the risk for pregnancy index, defined by measuring by ultrasound and for the newborn and the level of CA125. The ultrasound score is we have score 0, 1, and 3. Non-kilogram solid areas, intensity, arthritis, and the visual radiation. So by each one, you have to make it one score. And the score either green and green level, it is score 1 or positive score 0. This pregnancy index is less than 250 is lower or moderate is more than 250 is higher. Fecal ovarian cancer stage. We have stage 1 is confined either to 1 ovary or confined to 2 ovaries or a surgical stage. Surgical stage that when you are using the ovary, there is flow of fluid in the ovary. This could change the patient from stage 1A and B to stage 1B. Stage 2 is confined to cells, so either extension from the ovary to the tube and or stage. But Stage 3, the abdominal extensions of implant. The stage 4 is resistant defective. So what's the importance on knowing the stage, or not the stage in the surgical stage? Because the five-step survival rate for stage 1 can reach up to 90%, while the five-step survival for stage 4 is only 10%. So it's important to take patients safety warnings and monitor and once we diagnose this or suspect stage the ovarian cancer, we have to arrange an NPT meeting. The NPT meeting usually includes an oncologist, radiologist, pathologist, and radiology specialist of the staff. After we diagnose the condition in management, a clinical diagnosis, pathological diagnosis is obtained from tissue samples, either the primary laboratory, laparoscopy, or even diagnostic. Tissue diagnosis is particularly important in distinguish low risk from high risk of carcinoma, which is the reason that strategy in oncology. Beside the tissue examination, usually the CT and/or ultrasound serum identifies measurements of investigations facilitating the diagnosis and appropriate management plan. But in women under the age of 40, germ cell tumor is more common rather than fetal tumor. So in addition to protein, beta-FBG, and LDH. So the optimum calculations and survival, as there is a high correlation between optimum calculations and survival, it is useful to identify women who may require tertiary reference. So optimum calculations in advanced stage is movement to achieve tertiary symptoms, where specialists are specifically trained for gynecology and cancer subjects. The assessment of secondary care is based on important to subsequent diagnostic plan for patients with liver surgery. What is the general principle of surgical? The optimal surgical excision where there is no visible disease is left behind. So the first surgery is not important, not to see any visible disease left behind to take a better survival outcome compared to residual disease. So majority of my representative ovarian cancer, the renal primary surgery is permanent surgical staging as well as tumor excisions and the renal systems. The idea is a midline laparoscopy, not laparoscopy, of course. A midline laparoscopy and surgical management of ovarian carcinoma provides the opportunity to obtain accurate staging information. Removal of ovaries and infertility or mastectomy should be performed as well as peritoneal cytology. Where suboptimal staging can be performed, there is concern regarding the aesthetic disease in any person. So it's better to arrange an NPT meeting and consider a restaging by a dermatologist. Staging disease refers to the presence of malignancy to the ovaries alone. Such cases can be anticipated on the basis of tumors that are very chemosensitive. Research is reducing surgery is recommended in some chemotherapy. Chemotherapy can affect fertility, but in most cases it is transitory. With some desired treatment, nevertheless, the fact that the surgery and chemotherapy will adversely affect function. We all know that ovarian cancer is a chemosensitive solid tumor. The most common treatment regime is cisplatin or paclitaxel given for 6 cycles, with each cycle given at 3 weeks interval. Targeting mutations like primary disease inhibitors interfering with tumor blood supply and antivascular agents, but approved therapies become integrated here. This is adjuvant therapy with a treatment complication of activities. The new treatment and research will have the fever, zizuma, the brand name Avastin, with immunized monoclonal antibody that works primarily by inhibiting angiogenesis, the formation of the new blood vessels. So by targeting this process, it effectively cuts off the bottom line where the tumor needs to grow and proliferate and metastasize. So simply it stops the treatment, but prevent the new blood vessel formation. So it will stop the first line, it will stop the latent cells from this blood supply, making it easier to destroy. The other benefit is the PARP inhibitor. It's targeted cancer therapy that supports the first to fail in that cancer cell, preventing them from repairing their DNA and causing the cells to die. So this type of therapy is not effective against cancer that already has been weakened DNA repair system, particularly those who have mutations in microbiome environment. I think this would also work for breast as well as ovarian. So the new treatment and the choice we are looking for in the new therapy vaccine, there is European and Chinese trial has been shown some benefit or small benefit in secondary surgery after doing chemotherapy surgery. Just to increase the survival of the patients 8 months longer. Follow-up of the patients, usually 3 months follow-up for the first 2 years, and then 4 to 6 months follow-up for the coming 5 years, and annually after 5 years. Methods for follow-up usually by CA-125 as well as CT scan for suspected recurrence. What is important for a woman regarding the CA ovary is the support. The support should never forget the support for the patient that requires, and generally the abscess usually is a terminal condition. So besides support from the clinical nurse specialist, palliative care involvement may be appropriate depending on the scenario. Here usually from the RCOG, they are giving patients information regarding ovarian cancer. This includes the causes and the risk of ovarian and possibility that she might have, diagnosis, treatment may include, there is prevalence and the targeted therapy, support and the follow-up. So simple information can be given to the patient in order to know what's going on and what's going to happen. But the problem is still there for ovarian cancer. Still there is high morbidity and mortality because of late diagnosis, because of lack of research on ovarian cancer subtypes and the precision medicine treatment approaches for ovarian cancer, survivorship and supportive care still need. So incomplete understanding of the risk factor for ovarian cancer. Recently, in about 70-75% of women with ovarian cancer still present with advanced disease, that is FIGO stage 3 and 4. Symptoms often non-specific. As I mentioned, patient usually present with pelvic or abdominal pain. She may go to the GP having this pain. She may go to ophthalmic having abdominal satiety, or she may go to other dentist feeling why she's having weight loss. But for a period of more than 3 weeks plus, is a recognized reason to ask for a medical advice. Decreased appetite, weight loss, and alcohol level. As I mentioned before, some patients might have diarrhea, some patients might have even constipation, urinary frequency also may have. So she will consult all the doctors except the gynae. Usually reach the gynae in a matter of late diagnosis or advanced disease. So women therefore need to primarily refer to another gynecological specialist. Guidance for family doctors is available, whereby CA-125 and ultrasound should be performed. And we are referred urgently for oncology not more than 2 weeks, please. So conclusions, we have to concentrate on the infections, identifying high-risk individual, treatment option, future development, last but not least, not forget supportive care for the patients. Thank you.
Thank you, Dr. Raj. The floor is open for questions.
You have mentioned HRT in the increased risk. Like, do you recommend HRT or like, will you please talk about it?
HRT for ovarian cancer is a well-known cause for the increased incidence of ovarian cancer. Also, there is recent guidelines now, actually in November, it has been released that HRT is getting back to the field for the use.
So it's safe to,
We have to check with the patient if he doesn't have any risk factor, then we have to give it.
okay, thank you.
So, summary of the ovarian cancer from this presentation. The atypical, very non-specific presentation of a ovarian cancer. Initially, they may present as a just like lower abdominal pain, early satiety, and weight loss. Then initially they may present to the GP doctor for these symptoms, and it is treated by maybe simple analgesics and pain medication, and they get symptomatic relief. But if it persists for more than 2 weeks, then the patient must be referred to gynecologist, and then they will go for further investigation like initially ultrasound and other tests.
To reduce the size of the ovarian cancer, and then the program applications for surgery, for cyclooperations, and for complete debulking surgery.
The word debulking is generally used only in ovarian cancers. In other cancers, we don't use the word debulking. In ovarian cancers, the disease usually recurs again and again in the peritoneum. So our aim is to achieve what is called R0 resection. It means no visible tumor left there. Many times there are peritoneal deposits and nodules. Even these need to be removed. And our ideal debulking is when we leave behind less than 1 centimeter number. So the peritoneum can be studied. So nowadays, to improve our chance of an R0 resection, if we feel initially that the disease is advanced, we give chemotherapy first so that we have a better chance of an R0 resection later. And in these situations, we might proceed to do a biopsy initially to confirm the type of malignancy, decide on our chemo protocol, and then we will follow the cyclooperations.
Now for nice guidelines also the opportunity to do the traumatic stripping, liver stripping, cholecystectomy, appendicectomy, they can do all of these in order to make sure there is no residual disease.
Thank you, Dr. Ram. Just one question regarding patients with BRCA genes. Do you avoid the BRCA genes, BRCA1 and PCA1? Do you advise them conservative incorrect environment for them when they have completed that family? Is there is some recommendation considering?
Yes, I advise the patient having mutations in BRCA1 and BRCA2 is advised to do bilateral salvage of BRCA2 if she completes the family. It's very important. It's advisable.
The situation we mostly see in a patient being treated for a breast cancer where we have detected the BRCA1 and 2 mutations. So most of these patients who have received chemotherapy for her breast, and by the time she comes for her breast cancer treatment, we offer bilateral mastectomies and bilateral oophorectomies to her. If she needs to, she's keen on fertility preservation, we advise them to complete their family soon and then proceed to do a laparoscopic bilateral oophorectomy to reduce the risk of ovarian cancer in the future.
This family is you advise other members of the family to get testing and identify the
Ideal situation should be that they should first have a genetic counselor because they should know the pros and cons of genetic testing. Because if they test them, then there's a mental trauma on what will happen to their daughters and things. So ideally they should have a genetic counseling prior to testing. But yes, so we don't have adequate number of genetic counselors here. So I advise patients to do an online consults. There are some people in Europe who give online consults regarding genetic counseling, and these can help overcome the counseling which we may be inadequate.
the risk reduction in surgery of bilateral pterygium, sometimes the mastectomy also for the BRCA. Do you advise the HRT for diabetic patients like 40 or less than 40, or no need for HRT?
Generally HRTs are involved in breast cancer and endometrial cancer. Generally. So unless they are very badly symptomatic, we might consider. But in ovarian cancer, if we have removed the end organs, like uterus, we are only worried about breast. So we do adequate screening of the breast, and after treatment, they can be put.
But according to the recent FDA, which has been open to use the HRT, they can use local estrogen and progesterone and even testosterone in a woman who's having a CA breast. But I'm just asking you, if you are planning to do a tubal ligation, why don't you do something different rather than just ligation for the tubes? If the woman is asking for sterilization, will reduce the chance for a future CA ovary? What do you think?
Sorry, I didn't get it.
Instead of, because usually some patients they are doing bilateral tubal ligation, sometimes doing cesarean or without even cesarean. So why don't we do also better than BTL tubal ligation? We can do just simple saphenjectomy and with ovarian retentions, even if she's not asking for future pregnancy. What do you think? I'm asking just also my colleague. There's always in my mind this question, so why don't you do saphenjectomy? Since the risk is increased with the coming from the fallopian tube, as we all know.
But it needs lots of thoughts and the patient change their mind. We always do a triple ligation and make the treatment and for them to have a future. There's always a possibility like consider a family. And that's a very good effort. That's something very long-term discussion and should be lots of facts and comebacks and should be there. I do not think as a looking at it very relaxing for as a creation of that, the practice which I don't think. There is no proper recommendation. Guidelines or
Rest of the audience, our discussion was on saphenjectomy to reduce the risk. So whenever we try to reduce the risk of ovarian cancers, we have to address the tubes also because they also have a risk of cancer developing in the fallopian tubes, which are classified under ovarian cancers. When we do a surgery, usually removing uterus and removing the ovaries and the tubes to reduce the complete risk. In only a saphenjectomy, they will leaving behind the ovaries, so I don't know how much advantage that will be. And as Dr. Selva said, they might decide to decanalize or something. So,
So message to our GPs and family doctors, any referral to gynecologists, pelvic mass, abdominal mass, and CA125, any abnormal symptoms for a patient, especially menopause symptoms, any abnormal bleeding, we can refer every gynecologist for every patient. Thank you.
Thank you, Dr.
So thank you. This is going to the end of the seminar, and then there will be some post ceremony, and then the end of this today's seminar. Thank you.
Good afternoon once again, and we have come to the end of our CME session today. And ladies and gentlemen, we would like you to take a moment to honor our distinguished speakers for their invaluable contribution to today's CME session. Please join me in giving them a warm round of applause as we present them with our associations for sharing their expertise and insights with us today. We invite Dr. Supreet Shetty to come on stage